I'm going to introduce then the third speaker of this morning is Professor Leocadio Rodríguez-Mañas. Leocadio has been really a champion of geriatrics in Spain for many, many years. He was now appointed scientific director of the newly created area in cyber of the cyber and frailty and healthy aging. And I think it's very important that healthy aging in the name, and therefore this also gives us an opportunity to establish the interactions between some of the areas in cyber, that it's one also of the aims in order to foster the research in Spain, to increase the communication and also the collaboration between scientists working in different areas. Leocadio is the head of the geriatric department or the geriatric service at the hospital here in Getafe. No? So, thank you.
Thank you very much. So still good morning to all of you, and of course I would like to express my deep gratitude first to Eduard Montaña, who I met for the first time more than 10 years ago, taking advantage from a meeting we organized with Professor Alan Sinclair in the Royal College of Medicine. And I would also like to express my gratitude to Professor Ramón Gómez. When nobody was interested in the fields of diabetes in older people, probably he was one of the champions in the field of diabetes in Spain to pay attention to this, I think, very relevant field of interest in the field of diabetes. So, I am going to give a big jump coming from the two previous talks to this one that is very focused mainly on clinical management of older people with diabetes. And this means to try to put in the clinical context how many of these differences that has been raised by the two previous participants in this meeting has in some way modified the approach to the patients, all the patients suffering from diabetes. First, I will talk about how have changed the focus and the aims along the time, how the new challenge is to improve function, what is frailty and what is the importance of frailty in the prevention of disability and dysfunction in older people with diabetes, and to finally show you some very, very, very preliminary data of probably the biggest study up to now done in older people with diabetes focused on function. So, in 1922, all of you know that the first treatment with insulin took place. This is the first patient, and by that time, this was the focus on treating diabetes. Was put in type 1. In children and young people, the main aim was to save lives because of starvation. This is near 1 century ago. In the middle of past century, the focus have changed. The change was now on middle-aged people with obesity or with increasing BMI, with insulin resistance, with type 2 diabetes, and of course the focus will be again to save lives right now from cardiovascular diseases. And what now? Now this is the type of patient all person engaged in treating diabetes is facing. All the people with different functional status, and this is the true main focus for now. Is of course type 2, but in older adults, the focus is not to avoid death, but to avoid disability and to avoid dependency. This big clinical challenge, these big clinical changes in our main aims when treating the same disease, but in other patients, put the focus on the relevance not only of the disease, but also the relevance of the persons, of the populations we are treating. As somebody has told before me, in the past century we have a demographic transition. This means that from this profile, this shade of the distribution of the people in the populations, now we are like this. But in some way this has finished. In the past century, we go from a life expectancy of around 35 years on the starting of past century to 80 years at the end of the past century. But in this century, we are only going to gain, let's say, 5, 6, 7, 8 years of life expectancy from now to the end of the century. And this is because there is a limit to the life expectancy, not only in humans, but in any animal and any species. In addition to this demographic transition, that at the end of the day simply means there are more older people. And what else? What else is that we have had an epidemiological transition from non-communicable diseases that led the causes of death at the beginning of the past century to what has happened since the middle of the past century, that it's non-communicable diseases, ischemic heart disease mainly, but also cancer, is leading the causes of death up to now. So now we should face this third challenge, this third transition that I have called the clinical transition. If the patient is different, we cannot maintain the same ways of approaching them, because as they are different, they need different approaches. And this is what I'm going to dedicate the next 20-25 minutes. This is probably the main characteristics of older people as compared to adult and younger peoples. As you age, disease decreases in their importance to explain clinical manifestation of the disease, the pathophysiological roots, their prognosis value, and indeed the efficiency markers. And this role comes to function. So they need a clinical management and a systems design that is totally different to what we know until now. And this is because along the aging process, the biological reserve decreases. And this means that your functional reserve is going down and down and down. And when your functional reserve reaches a threshold, anything, any stressing is being manifested by a decrease in your functional status, because you are losing your capacity to respond to different stresses. And this is why, and this is very important to have in mind, when you are old, things are phenotypically manifested by changes in function. And indeed, when you look at the main prognosis factors, this is for death, but it's the same for other adverse outcomes, disease is not the most important issue. This is a nice paper published by the group of Landi in Rome, showing that these are people with multiple and single chronic conditions, no very high mortality. But in people with these same diseases, you add the role of disability, the increase of the risk in death is dramatic. So what is really putting at risk for death to these patients are not only diseases, nor comorbidities, but mainly the impact of these diseases on function. And indeed, when you try to see which are the costs, of the component of the costs of the diseases, here is a very recently published paper done by the group of health economy in the University of Groningen, showing that 80% of the cause of diabetes in older people is explained not by diseases, not by comorbidity, but by functional impairment induced by diabetes. And it's not necessary to be severely impaired, but with mild functional impairment, is good enough to have an impact on the economic costs of the disease. So both in terms of quality of life, both in terms of risk, and both in terms of costs, function, when you are old, are the main culprit, the main component. Following with economy, this is a very big champion of the economy. You know, he's Sir John Maynard Keynes. He was awarded the Nobel Prize in Economy, and he uses to use this sentence: when the facts change, I change my mind. What do you do, sir? We should not stay doing the same things when the things are different. So if we have different patients, we should accordingly change our minds. In which sense? Putting the focus on the true problem, that is function. Not many diseases, not multimorbidity, but mainly function. And this means that we should break the clinical inertia from curing to caring, from disease to function, from survival to quality of life, from to-do to assess very accurately the risk to benefit ratio and taking into account what not to do, and of course, taking in our minds or having in our minds that interventions must be timely put in hand. And this also means that the characteristics of these innovative frameworks are very different from the classical framework we used to put in practice. What is the role in this management or different management of the patients with diabetes, of frailty? When you, as you age, you in some way go through a pathway from the most robustness part of your life to this part of life that you are progressively or increasingly be less fitted, very functionally fitted. But there is some place in this pathway from robustness to highly disabled people where reversibility is going down and down and down. Remember when I told you that as you age, your functional reserve was going down and down and down. To reverse the effects of any injury, you need functional reserve. So if you do not have functional reserve, the probability of reversing the condition is going down and down and down. Look at this study published some years ago. They show that when you are disabled during the cases during an acute medical illness, episode of hospitalization for acute medical illness, only 30% of the patients that had or experienced a poor functional status at discharge was able to recover. Only 1 in 3. So we need to diagnose the condition of those people at risk for developing disability earlier. If we wait for detecting the condition when they are disabled, we are late. So instead of working on this time, that is the usual time, this is the appropriate time for detecting and also for intervention. And this is the time of frailty, that it's a condition that precedes the disability and indeed is clearly manifested by some quite clear signals. In a very intuitive way, frailty is the interaction between the aging process and some diseases and conditions. One of them, diabetes, is one of the 6, 7 more usual conditions leading to frailty when they interact with the aging process. This is the definition of frailty, and this is the clinical criteria, very simple to be measured, non-sophisticated at all. So every physician, every nurse can detect frailty in older people. It's not very difficult. It's less sophisticated than making an echocardiography or any of the procedures we used to practice to our patients in the clinical daily practice. It's different from disability and it's different from comorbidity. And why is so important frailty? Because frailty is the main risk factor for incident fall, worsen mobility, worsening activities of daily living, disability, first hospitalizations, and death. And one of the diseases where frailty is more common is in people with diabetes. Approximately 25% of all the people with diabetes are frail. So, inside this general framework about aging, about frailty, what about diabetes? All of us know that diabetes is a high-impact disease, but it's forecasted to increase its incidence and prevalence in a very significant way in the next 15 years, 20 years. Imagine that, in addition, this increases in prevalence is going to be shown everywhere. Of course in Europe, but also in South America, North America, Asia, everywhere. But who are the leaders in this increase in the prevalence of people with diabetes? Mainly older adults. These increases in prevalence are not going to be led by people 45. It will be in some way marginal in people from 45 to 64, and is going to be led by people 65 and older. In fact, now, currently, near 60% of all people with diabetes are older than 65. 2 in 3. Which are some of the main characteristics differential characteristics of diabetes when you are 75, 80 than when you are 40 or 45. This is one of the most important. In older people, diabetes only marginally increase your risk of time. In older people, diabetes is not a cause for death, but this is very important. It's one of the most important causes of functional disability, including also an impact on cognitive dysfunction and other very relevant adverse outcomes when you are old, like falls and fractures. Older people who have diabetes are at a higher risk for functional disability, for impaired cognitive dysfunction, and falls and fractures. But at the same time, diabetes is able to produce frailty. This is a recently paper published by us showing that diabetes is associated with a higher risk of frailty after only 3.5 years. It's not necessary 20 years to develop frailty when you have diabetes. And how is the relevance of this risk? 2.18. It's a significant risk. And which are the main components associated to diabetes that means to explain, that means to account for this increased risk? Unhealthy behavior, a poor glycemic control, and altered serum lipid profile. When we talk about poor glycemic control, what are we talking about? We are talking about glycosylated hemoglobins higher than 8%. And it should be an important part of the management of people with diabetes. And I will show you later on some other things. Of course, this impairment in function impact on mobility, but also on instrumental and basic activities of daily living. It's not the same to walk to a lower speed than to be dependent to bath, dressing, eating, or going to the bank. So to manage your economic issues. Diabetes impacts on all of these parts of the whole picture of functionality when you are old. Of course, increase the risk of cognitive impairment and dementia. And again, frailty is the most important predictor factor in people with diabetes when you are old to have incident disability and for death. When you include in your formula to assess risk or death or incident disability, when you include frailty, Charlson index, that it's a way of measuring comorbidity, has not had any more capacity to explain. So all the effect of comorbidities in explaining, in accounting the risk due to diabetes are accounted by their impact on function, on frailty. Because when you adjust by frailty, diseases no longer have any role in predicting death or disability. I have told you before about the relevance of time. Things happen along the time. And there is a very good concept that it's lag time to benefit, that this has been defined as the time between a preventive intervention, treatment or prevention, to the time when improved health outcomes are seen. And this is very important when you are treating people with a reduced life expectancy. When you are 80 or 85, you do not have 20 years to have the benefits of any treatment. And look at the time for benefits, cardiovascular disease, from interventions in people with type 2 diabetes. This is the effect of lowering hemoglobin A1C on microvascular diseases. You need 20 years, but people with 65, 70 do not have 20 years to experience the benefits. So they are going to experience the benefits 10 years after death. And you know that when you are die, no any other thing happens to you. So if we are trying to avoid microvascular disease here, we are going here to try to avoid a macrovascular disease in a man or a woman that is dead. No way. And when you talk about microvascular diseases, we are talking about microalbuminuria, for instance, that, as all of you know, it's a very disturbing condition for patients. Do you feel really that microalbuminuria is a really disturbing condition for patients? What do they feel, a patient with microalbuminuria? Nothing. Nothing. Why is it important to detect microalbuminuria? Because it is telling to us which patient in 10, 15 years is going probably to need hemodialysis or a kidney transplantation. In another 10, 15 years, and in another 10 to 15 years, he or she is going to be dead. And people who is dead do not need any kidney transplantation or any hemodialysis program. But what about function? You are able to develop frailty not in 10 years, but in 1.5 years, mobility disability in 2 years, dementia in 3-4 years, and dependency for basic activities of daily living in 5 years. So indeed, when you are very old, you must be protected for these outcomes. So in people who are old, these are the main outcomes to be approached and protected. And in the balance between treating and the risk of treatment, it's very important to take care about the secondary adverse reactions. And one of the most important of them is probably hypoglycemia, with a very special issue when you are old, is that when patients experience hypoglycemia, 95% are asymptomatic. So many hypoglycemic episodes in older people are not detected by the patient, and it's not detected by the proxies. And in addition, if you do not ask quite clearly when you see to the patient in your office, they are not being detected at all. So when you think in which terms you must manage all the people with diabetes, you need to have in mind this bilateral relation between diabetes and function. We have seen that diabetes impairs function, but although function in some way should mark the management of diabetes. In which way? In this way, we need to improve the quality of life of our older patients, mainly in our frail older patients, coming from longevity to quality of life, and our approach should be based in management chronic disease oriented to avoid frailty and preserve function. We should manage frailty as itself, as the phenotypic expression of disease, and promoting an integrated, coordinated, and continued care to maintain quality of life, not to prolong life. And this means that, for instance, that when we are designing a research clinical trial in other people, we are not interested in assessing as the first outcome the deaths that we are eliminated. It's not interested. And probably it's not possible, because when you are very old, things different from age and gender only explain 15–20% of your risk of time. But we should put the focus in function. And when we manage the care of the patients, we are going to decide the management dependent their functional status. And this is why we, or several geriatricians and physicians in working on older people, have produced this kind of algorithms. In this algorithm published by Professor Sinclair, Tricia Dunning, and me 2 years ago, we say that this is the proper way to approach people with diabetes, with the aim of defining functional categories. And depending upon the functional categories, we are going to change the management of the older people with diabetes, not depending upon the retinopathy, not depending upon the microalbuminuria, but depending upon the functional categories that are the one defining the risk for death and disability. And for doing so, we need to change our clinical assessment of older people with diabetes, including all of these factors that are going to produce or modulate or modify the outcome of prognosis of the patients. And we need to individualize targets and treatments with lifestyle modifications, physical exercise and nutrition, drugs allowing to achieve the targets, but with the lowest risk of adverse reactions, mainly hypos and Folsom fractures. So when we are thinking in a drug, we, of course, should think in how to achieve the glycemic target, but also, and this is very important, the safety of the drugs is a first conditionant, not the conditionant number 10, the first conditionant in order to choose the proper drug. Which kind of intervention? As in an adult person with diabetes, meaning lifestyle changes, physical exercise and diet, but also lifestyle, but also drugs. This is the first document putting all of these things in value. Was published only 6 years ago, in 2011. And in this document, we address the issue depending upon the functional status of the patient. The glycemic targets, but also the blood pressure targets, but also the cholesterol targets, but also the nutritional interventions depend on their functional issues. This was only 6 years ago. The next year, the following year, it was another document from experts, but probably we will be the same. But that same year, the ADA, in a document jointly with the American Geriatric Society, in some way adopt our way of thinking the issue. And the next year, at the end of 2013, IDF, that you know it's the executive arm of WHO for issues on diabetes, published this guideline. And he said, specific recommendations are made for each of the functional categories. This means that if you do not establish functional categories, you are not doing the best approach, the standardized approach. So if not possible to manage properly to other people with diabetes, if you do not establish the functional categories, and this was the functional categories they proposed, and the glycated hemoglobin target. Look at this. Never lower than 7. Never. Indeed, when the patient is functionally independent, never lower than 7%. And indeed, in the next years have been some other standards of medical care in diabetes for some settings of care. This is the care of long-term care and skilled nursing facilities that was published last year by Mera Monshi, is the one in charge of the program for all the people with diabetes in Joslin, and all the collaborators. And the scope, the focus, is quite similar. Depending upon the functional status, your aims, your objectives are quite different. But when you go to the reality, you see that still we have an over-treatment in many patients. This is data from the United States of America, and 50% of patients are over-treated. But it's also the same in Spain. We have recently, it's in press, but it's admitted. And in Spain, 43% of all the people have a glycosylated hemoglobin A1C lower than 7. They are over-treated. Which kind of drugs? Taking into account that safety is of first value when you are trying to treat diabetes, it's quite clear which are the first one. Those with the lower problems of hypos, mainly metformin and IDPP-4. These are the two main drugs that are useful when you are treating other people with diabetes. And an additional thing, many physicians are really scared about using insulin. Insulin is quite safe if you use it properly. Mainly take it into account that we are not trying to put the patients with a glycosylated hemoglobin of 5.5 or 6. If we put the focus or put the target in levels of glycosylated hemoglobin like 7.5, probably an association of a basal insulin plus an IDPP-4 or metformin could be a very good regime for treating diabetes in these older people. But if you see all of these guidelines and go to the quality of the evidence and the strength of the recommendations, the quality of evidence is not very good, and because of that, the strength of recommendations are not very high. So we need two main studies in all the people with diabetes, and mainly in people who are at the highest risk for becoming disabled, that is, frail older subjects. And this has been the aim of Meet Frail. This is my 5-6 last slides. That is a randomized clinical trial to evaluate the effectiveness of a multimodal intervention. We have been talking here that aging and diabetes is a multifaceted issue, so the approach should be also multimodal intervention in older people who are frail, and which is the aim of the study, to assess the impact of this intervention on function and quality of life. Well, you know, it's a very big project funded by the EU with 17 partners, and it has finished 4 months ago. We are now analyzing the data. As I show you, this is the point in the pathway from robustness to disability where we are trying to intervene using physical exercise, strength physical exercise, non-aerobic, only strength, a regime very easy, 30 minutes, twice a week, plus a nutritional education mainly focused to avoid malnutrition and detecting hypos, and changing the target for glucose, a glycosylated hemoglobin between 7 and 8, and for blood pressure lower than 150 of systolic blood pressure. This is the main objective in terms of function and quality of life. And these are very preliminary results. I don't know if you are familiarized with SPPV. SPPV is probably the most used instruments to assess functionality when you are still not disabled. And it says that improvements in 1 point or more are clinically relevant. And this is our main result. In people who are in the intervention group, there is an increase in 1.5 in SPPV, while in the control there is no any changes. So for the first time, we have shown that an intervention centered in functional issues in all the people with diabetes, around 1,000, 976 or something like that, produces impact on the functional status of all the people with diabetes. So in conclusions, these are my main messages. First, think in the patient, not in the disease. You are treating all the people with diabetes, not diabetes in all the people. And in fact, the name of the document from the IDF is all the people, managing all the people with diabetes, not managing diabetes in all the people. There is a relationship among diabetes in several sectors of function. Sometimes diagnosis is a challenging task, but because of that, be aware and screen. Make the drug treatment as simple as you can, less drugs, prioritize those who can be done once per day. Safety is not the third or the fourth issue, it's the first condition in the choosing of the drug. Malnutrition is the true nutritional problem. Avoid restrictive diets. Any physical activity is better than no activity, and be respectful of patient care and family thoughts. In these patients, their opinions are of particular relevance and are not exactly the same that the physician has. They represent 60% of persons with diabetes. They show different characteristics. They need different approaches and different managing. Frailty is very important, and because of that, it must be assessed in any other adults. In order to provide the best fitted care to the patients, we should move toward this new age in diabetes. This is me. Wait, sorry. Oops. That's me. That's me, but of course I'm not a fashion model. No. But I would like to show something that it's here. Probably clinicians have been aware about that is this. This is a pen of insulin because I have type 2 diabetes. And if I become older and I become an old patient with diabetes, I would like to receive a treatment inside the framework I have now showed to you. Thank you very much.